first talk is Effect of Failure to Rescue on Hospital Volume Mortality Relationships in Cardiovascular Surgery, presented by Dr. Gonzalez and his colleagues from the University of Michigan.
Good morning. I'm Andy Gonzalez, and I'd like to thank the Academic Surgical Congress and our moderators for this opportunity to present. I have no relevant disclosures, nor does Dr. DeFury. Drs. Dimmick and Bergmeyer are consultants and equity owners in Arbormetrics, an Ann Arbor-based healthcare analytics and information technology firm. Arbormetrics is not involved in whole or in part in any collection or analysis of any data presented herein. In our national debate on healthcare, medical errors and patient safety feature prominently in the minds of patients, providers, and policymakers. Central to the discussion of hospital quality is a significant variation in hospital mortality rates. Depending upon operation, hospitals with the lowest mortality rates have nearly fourfold less mortality than hospitals with the highest mortality rates. High-volume hospitals tend to have lower mortality rates, and this has been demonstrated for cardiovascular disease, oncology, and for trauma. Historically, volume outcomes relationship has been assumed to be mediated by lower complication rates at high volume centers. However, in cardiovascular surgery, there's been significant standardization of perioperative care. To investigate the effect of failure to rescue on the volume outcome relationships for these operations, we use Medicare provider analysis and review files from 2 years, and we included patients between the ages of 65 and 99 who underwent coronary artery bypass grafting, aortic valve repair, or open AAA. Our final study population included 119,000 patients. Our primary outcome measures were risk-adjusted 30-day mortality, major complications, and failure to rescue, as defined by mortality after major complication. We use standard techniques to generate risk-adjusted rates of 30-day mortality based upon a logistic regression model accounting for age, gender, race, urgency of the operation, and pre-existing medical comorbidities. We then stratified by hospital procedure volume and compared the highest and lowest volume quintiles. We found that there were no differences in any significant preoperative factors with the exception of black race for aortic valve repair and aortic aneurysm repair. Our results showed that for risk-adjusted hospital mortality rates, there were differences between the lowest and highest volume quintiles. These were significant across operations. With respect to major complications, for coronary artery bypass grafting, there was no significant difference between complication rates between our two cohorts. However, for AAA repair and aortic valve repair, there were significant differences. However, these differences were small in magnitude. In analyzing failure to rescue, we note that there are statistically significant differences across all operations between the highest and lowest volume cohorts. We see that the odds ratios for these differences is higher than the odds ratios for the major complications. In summary, this means that while there are small but statistically significant differences in complication rates, there are much larger differences for failure to rescue rates. This would suggest that failure to rescue may mediate the significantly lower mortality seen at high volume centers. Early recognition and appropriate action may be a way to prevent the domino of complications leading to postoperative mortality. Patients who suffer postoperative mortality often undergo a sentinel event, which is their initial complication, which leads to a domino of other complications. Appropriate recognition and taking action are possible ways to produce an intervening disruption in the postoperative mortality pathway. The ability to enact such a rescue is influenced by the availability of hospital resources and by the behaviors and attitudes of caregivers. In this context, our results imply that as a mediator of mortality, failure to rescue may be an important target for quality improvement. We urge that hospitals adopt a holistic approach when optimizing their postoperative care pathways. This may include leveraging attitudes such as team communication and safety climate to ultimately provide better care for our patients. Thank you for the opportunity to present. I'd like to thank the Academic Surgical Congress and Dr. Wakefield for his generous support with an institutional training grant, and Drs. Rouhani, Brown, and Benedetti for providing me time off for dedicated research. I'd be happy to take any questions.
This paper is now open for discussion. Andrew, that was very nicely presented. I have one question for you. It looked like you looked at 3 different procedures and did the stratification across those procedures, because 2 of the procedures are cardiac and 1 is vascular. Was there any consideration to moving by that, since there seems to be shared resources between CABG and your
We did not consider grouping those 2 operations together. However, it was interesting because for CABG there were no differences in complications. However, for aortic valve repair there were differences. This may represent the fact that more centers do CABG and there's a higher volume than for aortic valve repairs.
Right, so it's a question if there's an effect with hospitals that do a better job with CABG that would spill over to.
Well, it appeared that as far as failure to rescue, there were differences for both, but as far as complication rates, there did not appear to